Greetings from Fourrts. We welcome all the participants to this international webinar on Ketoalfaanalogues supplemented low protein diet, a new era. The right topic during this Diabetic Awareness Week in India. On behalf of Fourrts, we thank today's chairperson, Professor Dr. P. Soundarajan sir, and moderator Dr. P. Ravichandran sir for their time. We also digitally welcome and thank today's international speakers from Bucharest, Romania, Dr. Liliana Garneata and Dr. Carmen Antonia Mocanu to India for accepting our invitation to talk today. Fourrts is in the pharma industry for the past 43 years, following the motto of innovating for good health. We are the pioneer and leader in nephroprotection with brands like NephroSave, NephroSave Forte, and NephroSave Keto. Our Ketoalpha analog brand, NephroSave Keto, is the most affordable brand in the market, which is available as both tablet and sachet to reduce the burden of your patient. At present, we are exporting our products to over 50 countries around the globe. Our today's chairperson, Professor Dr. P. Soundarajan, is a senior consultant nephrologist from Apollo Hospital, Jubilee Hills, Hyderabad. Professor Dr. P. Soundarajan sir has 35 years of medical teaching experience in various medical colleges in India, from lecturer to head of the department. He has helped in various PhD programs of his students in SRMC. Professor Dr. P. Soundarajan is the member of Governing Council of ICMR. He is the member of governing body of PGI Chandigarh. He has received several awards like Dronacharya National Award in Nephrology from Avatar Delhi Nephrologist Forum and Lifetime Achievement Award from Dr. MGR Medical University. He has, to his credit, nephrology article publications in 21 international and 26 national journals. Today, our moderator, Dr. P. Ravichandran, is Associate Professor from Savitha Medical College and Hospital, Chennai. He is the Head of Nephrology and Transplantation in St. Thomas Hospital, Chennai. Dr. Ravichandran has an experience of 25 years in the field of nephrology and transplantation. He is running Nephro E-Club, connecting 950 nephros across India. He is a trustee of Kidney Care Society. With this short introduction, I hand over the session to the chairperson, Dr. Professor Soundarajan sir, for his opening remarks.
Welcoming our overseas friends who come their own hands-on experience to make the ignorant to get highlighted, non-believers to believe, and convert us from the era of non-believers to believers. I'm sure so-called non-believers will also become believers at the end of this forum. Believe me, I've been practicing for 35 years. The moment I tell my patients dialysis, 3 questions they ask me. Is it dialysis? Is there any medicine to avoid dialysis, to delay dialysis, or no dialysis? So alas, I used to look at the roof and pray, I have something. So accidentally, I fell upon this one of my overseas patient's prescription in a rural medical college 30 years ago. That's the time I started looking at this literature and new arrivals. You have to believe me that I've been one of the longest successful user of keto analogs for almost 3 decades. It has helped my patients, not invariably every patient. You choose appropriate patients in select situations, start them early, along with other risk factor correction and proper follow-up. You have to believe me that I have delayed dialysis patients. I have given symptomatic relief for many of them. I am a strong believer of that. Many more things to listen from our overseas friends, Dr. Liliana and also Dr. Carmen. So with this brief introduction, I welcome all of you. I am allowed to listen to our speakers. Thank you very much.
Now
I would like to introduce Dr. Liliana Garneata, a well-known figure. She is from Romania, associate professor with doctoral rehabilitation at Carlo Davila University of Medicine and Pharmacy, Bucharest. And she is heading the unit and department at the same teaching hospital of nephrology. She is the director of Romanian Renal Registry since 2007. She has vast publications, more than 80 papers in national and international levels. She has achieved many scientific citations and awards, and also a member nominated by ERA-EDTA Council, and was an associate editor of BMC Nephrology Journal. Her special interest is epidemiology of CKD, nutrition and metabolism in kidney disease. Many of her lectures we have listened, and her publication we have read, and special interest on renal anemia. Today she is going to talk to us about ketoanalogues and low protein diet in CKD. And I also like to welcome Carmen Antonio Macano, who is a PhD student, a resident physician in nephrology, working along with Dr. Ileana. And she is, her special interest is also, and she is working on diabetes and the role of low protein diet and keto analog supplementation in preventing progress of CKD. She has presented many papers in various conferences online as well as poster presentation. And we would like to hear her case studies, which she is going to present after Professor Liliana Garneata finishes her lecture. I request Dr. Liliana to take the stage and talk to us about your study, madam.
Thank you. I'm grateful for this invitation. And I also like to thank you, Mr. Chairman, Mr. Chairperson, for your kind introduction. Now I'm going to discuss, as you have mentioned, about keto analog supplemented protein restricted diets coming into a new era, coming on a wave again. And let's start. I'm not sure I can move.
You just click on the slide and then move, ma'am. It'll go.
Okay. Now it's too much. Good. So low protein diets seems to be useful to postpone renal replacement therapy. And there are data coming back from 1974, mainly from Italy. They mentioned the possibility to postpone dialysis through the diet by a better metabolic control. And the Italian colleagues were talking about improving the nitrogen balance, correcting metabolic acidosis, and correcting calcium phosphorus metabolism disturbances. So these are metabolic data. But then the modification of diet in renal disease study, the largest trial designed to check on the effects of low protein diet on the progression of chronic kidney disease, come with the conflicting results. And then the interest of the people for low protein diets decreased significantly, both in physicians and in patients. But more recently, there are data that a low protein diet allows for a better control of blood pressure and for reduction in proteinuria. And we all know that both these aspects are influencing the rate of decline in kidney function. So it is reasonable to think that using a low protein diet, one can reduce the rate of decline in kidney function. There are also data of the possibility to ameliorate the insulin resistance by protein restriction. And this is particularly important in this era when the metabolic syndrome is coming more and more. Now, this is a slide that I like very much, coming from Professor Kalantar-Zadeh in the United States and Denis Fouque from France. They are showing, in my opinion, very nicely the role of the low protein diet in changing the hemodynamics inside the glomeruli. We know that ACE inhibitors on sartans are producing vasodilation on the efferent arteriola, and this way it decreases the intraglomerular pressure. Therefore, the rate of glomerulosclerosis is reduced, and therefore the rate of decline in kidney function is reduced. On the other hand, we all agree that a low sodium diet decrease blood pressure and decrease the intraglomerular pressure, and again, the glomerulosclerosis. But it is particularly neglected that a high protein diet goes with vasodilation of the afferent arteriola. That means increased intraglomerular pressure, so an increase in the rate of progression of glomerulosclerosis. Therefore, taking a protein-restricted diet, we will have vasoconstriction of the afferent arteriola, and again, a reduction in the intraglomerular pressure and in the rate of decline in kidney function. In other words, the low protein diet comes together with a low sodium and with ACE inhibitors in order to protect the glomerulus against glomerular sclerosis. Now, of course, there is not a single low protein diet. There is nothing that fits all. So we give in our normal practice, of course, an individualized approach to low protein diet. But just for the reason of this lecture, I would like to comment some of the terminology. Like we are using a conventional low protein diet, 0.6 gram per kilo per day, and I'm going to abbreviate it as LPD. Then we use also ketoanalog supplemented low protein diets, which means 0.6 gram of proteins per kilo per day, plus ketoanalogs, 1 tablet for 10 kilos of dry body weight. And we are calling this type of nutritional intervention SLPD. And then there are the very low protein diets, 0.3, 0.4 gram per kilo per day, again supplemented, either with essential amino acids or with keto analogs, 1 tablet for 5 kilos of dry body weight. And we are calling this SVLPD. In our publication, we mentioned this type of nutritional intervention as keto diet and is abbreviated in many of those slides as KD. But since there is an analogy with the ketogenic diet, which is currently largely promoted, we decided not to use this term of keto diet anymore in order not to leave any confusion between this SVLPD and the ketogenic diet. That's nothing to do in between. And I would like to share with you some of the data that we have from our clinical practice. And this is a study that we published in Journal of the American Society of Nephrology 4 years ago. It is a randomized control trial in which we compared conventional low protein diet, the LPD here with 0.6 gram per kilo per day, with SVLPD, which was 0.3 plus keto analogs. We included non-diabetic patients, only non-diabetic patients with stable CKD stage 4 or more, with low proteinuria and in good nutritional status. The total assessment period was of 15 months. There are 2 points I'd like to make on this slide. The first of all is that by study design, we introduced a run-in phase during which low protein diet has been prescribed, and we have particularly checked for patients' compliance. And only the patients who proved compliant during this run-in phase were randomized. This was 1 point. And the last point I'd like to make is that we have assessed for eligibility more than 1,400 patients. And we randomized, just 207. This is about 15%. In other words, just about 15% of the patient who would benefit from a low protein diet is able to accept and also to be compliant to this type of protein restriction. And which were our results? Just 13% of the patients receiving SVLPD required dialysis or experienced severe worsening of kidney function, as compared to 42% in control. And the difference is obviously significant. But maybe more important is that even we have adjusted this data for the other parameters known to interfere with the rate of progression of CKD, like proteinuria, like blood pressure, like body mass index, etc., the difference still remain between the two types of nutritional intervention. How effective is this type of vegetarian, very low protein diet? And we have looked at the numbers needed to treat. And our data showed that it is mandatory that 3 patients receive nutritional intervention for 1 year in order to prevent dialysis in 1 patient. And for comparison, we have to look, for example, at the statins. All of us take statins. We have to take 20 patients have to take statins for 3 years in order to avoid heart attack in just 1 patient. So it seems that a low protein diet is more effective in preventing dialysis than statins in preventing cardiovascular events. Now, how does it look on a long term? The first question would be, is it possible that somebody to follow such a high protein restriction for a long time? And the second one, which is the influence on the long-term outcome of the patient and on the kidney? This is an important question, particularly because there was a follow-up of the patients in the MDRD study. And the results of that follow-up, published years ago by Menon and couple, they showed poorer survival in patients receiving SVLPD. So we try to look also on a follow-up perspective to our patients. And we compared the longer-term effects of SVLPD and LPD respectively on renal outcome, on survival outcome, and on the nutritional status in the same, of course, again, non-diabetic patients. And this follow-up study assessed the state of all the patients previously participating in the RCT 2 years ago. And it is important to note that the enrolled patients voluntarily continued the previous diet and the previous monitoring schedule until starting dialysis or until their death. And we started this follow-up study with 200 patients, 101 in the SVLPD and 99 in LPD, with no differences between groups with respect to age, gender, or primary kidney disease. It looks complicated, but I'd like you to focus on the following aspect, that in patients previously on SVLPD, just 83% of them were still alive 2 years ago, as compared to only 64% of patients in the control group. In other words, it seems to be a survival advantage. And if we look at the median time to follow up, it's quite impressive that the people in the SVLPD have been followed for 100, this is the median, for 129 months, which is more than 10 years, as compared to 119 months in the control group. Now, looking at the probability of patient survival at 5 years, it turns out that the probability to survive at 5 years in the SPLPD group was significantly higher, 96%, as compared to only 82% in controls. In a multivariate regression analysis, we have included also other factors known to influence survival, like, of course, age, gender, modality of dialysis, and the comorbidity score. And in this analysis, only the type of nutritional intervention was associated with the survival advantage we have mentioned. Now, for the kidneys survival, just 51% of patients in the SVLPD group needed dialysis. And again, we are talking about more than 10 years, as compared to 93% in the control group. And very interesting, when we talk about compliance in patients still alive and still not on dialysis, the compliance to the diet remained excellent. People taking before SVLPD were still compliant to 0.3 grams of protein per kilo per day. And the people previously on LPD were continuing this LPD with 0.6. There were no significant changes in the nutritional status in any arm. It seems it was a little bit better nutritional state in patients previously on SVLPD, as judged by the subjective global assessment score. And there was also a lower level of CRP in patients on SVLPD. Now, what about diabetic patients? And I know that in India and in Asia in general, there is a huge interest for diabetic patients because CKD has frequently as a background the diabetic kidney disease. And there are also in diabetics the hemodynamic effect and the metabolic effects that I have mentioned. The first data looking at the diabetic patients are coming from a Czech group of Professor Teplan, who compared, it's a randomized control trial in which he compared low protein diet plus ACE inhibitors represented in white with low protein diet plus ACE inhibitors plus keto analogs. And it turns out that in patients receiving keto supplementation, proteinuria decreased significantly and remained lower throughout the study. Again, that's we are discussing about diabetic patients only. And probably more important is when we look at the GFR, that the rate of decline in kidney function was significantly slower in patients receiving also keto supplementation. And we try to design and to conduct a study in our clinic, looking at patients with advanced diabetic kidney disease and with severe proteinuria. As we have discussed below, we are talking about the real diabetic nephropathy. This is a single center prospective trial. So far, there's no control group, but in the future, probably we'll manage to add a control group to this experience. And we designed this study again with 3 phases, keeping this run-in phase during which we have assessed compliance. And then during the intervention phase, we administered in our patients, or we recommended 0.6 gram per kilo per day proteins, mixed protein this time, plus keto analogs, 1 capsule for 10 kilos of body weight. And the results are, in our opinion, impressive. Proteinuria decreased significantly from 5.2 to 1.6. In other words, with 3.5 gram per gram of urinary creatinine, which is 70% of the initial value. Now, if we look at the kidney function, Before enrollment, our patients used to lose 6 meals per minute per year in their GFR. But then during the intervention phase, the rate of decline decreased to 1.3 meals per minute per year. This is 5 times slower. For the blood pressure control, the red lines are the medians, and one can see that during the study with protein restriction, we were able to reduce the blood pressure in our patients by 11 millimeters of mercury. I'm sorry. There were also other interesting metabolic effects. There was an increase in serum albumin, a decrease, significant decrease in C-reactive protein level, and a significant decrease in the body mass index. So to summarize the data we have so far, in patients with diabetic kidney disease, it seemed that SLPD is able to control, to allow a better control of blood pressure, to reduce significantly proteinuria, and to reduce the rate of decline in kidney function. And what I like the most in this slide is these two lines. The red line represents the trend in eGFR, considering the historical data of the patients. And the gray line is the actual evolution of GFR. And one can see that it was expected that in 10 months, all the patients to be already on dialysis. And what really happened was that none of the patients required dialysis. And again, the rate of decline was 5 times slower. So to conclude, the vegetarian severe hypoproteic diet supplemented with keto seems to be effective to postpone dialysis, of course, in compliant and closely monitored non-diabetic patients. It is feasible on long-term in our experience and associates better patient survival and also better kidney survival. The keto analog supplemented low-protein diet seems to be effective and safe in diabetic patients for a reduction in proteinuria with 70%, for a better blood pressure control, and also to reduce the rate of decline in GFR in our experience 5 times. And this is a slide I like a lot. And despite the evidence I have presented, diet is still kept as Cinderella, dominated by her stepmother dialysis and stepsister renal transplantation or ACE inhibitors or sartans. But now with the new released KDOKI guidelines from the National Kidney Foundation, there is a new light for the low protein diets, because protein restriction is mentioned in these guidelines as evidence level 1A. So it's strong recommendation to use a protein restriction. So probably in the future, there will be no need to add this slide with Cinderella. So to cut Cinderella from here and to leave just this flower with a patient in the middle, and various specialists like nephrologists, nutritionists, cardiologists, diabetologists, dietitian, etc., working together as a team to manage this complex situation of the patient with advanced chronic kidney disease. And I thank you very much again for the invitation and for your attention. And I will be very glad that we discuss together on that experiences. Carmen?
We'll go to the next case presentation by Carmen Nakano.
Sir, I need 2 minutes time, sir. I need 2 minutes. So thank you so much, ma'am. It was a wonderful session. I think now we'll move on to Carmen ma'am's case study. Before that, a small brief, because I think many people are there right now, because initially there are only flow people. So once again, I thank our international speaker. We are on the middle of this keto alpha analog supplementation, low protein diet, a new era topic on this right time. That is the diabetes week is going on, awareness week is going on in India. So we thank once again Dr. Professor Soundarajan sir and Dr. Ravichandran sir for accepting our invitation and having the time today. And also we thank the international speakers from Bucharest, Romania, Dr. Liliana Garneata and Carmen Antonia Mocano, madam, once again. So to talk about Fourrts, just 2 lines about Fourrts. So Fourrts is in the pharma industry for the past 43 years, following the motto of good health. And we have very good nephroprotective ranges in India. As madam was talking a lot of things about nutrition, NephroSave, NephroSave Fort and NephroSave Keto. And a very, very important thing is the compliant of the patient, so we can offer a affordable brand in the market. We have a NephroSave Keto tablet in Indian market at a very, very affordable price for the patient, which can save a lot in today's pandemic situation as well. At present, we are exporting our products to over 50 countries. So now I hand over the session to Carmen Antonia, ma'am, for her case study presentation. I liked your that Cinderella picture, ma'am. That was good, actually.
Thank you.
Yes, ma'am.
Okay, I want to thank you for your invitation to speak today about the experience of our clinic for approaching hypoproteic diets at young and elderly patients in light of 2 case presentations.
Your slide is not full, ma'am. Right side, there is a comment. I mean, this one is coming. Your notes are also coming.
Now it's okay?
No, half slide is coming, half your notes is coming. So you bottom, you just click on that, the bottom, you go to the bottom, ma'am. No, again, that same is coming. You just go to the bottom and then right hand side. Can you see the minus button? Yeah, full screen. There is a minus button before the minus button. Yes, perfect.
It's okay.
Yeah.
Okay. I want, first of all, to thank you for your invitation to speak today about the experience of our clinic for approaching hypoproteic diets at young and elderly patients in light of 2 case presentations. In the first clinical case, I will discuss about the nutritional intervention in a young non-diabetic patient with chronic kidney disease. A 45-year-old male patient is presenting in our clinic for the first time in 2015. From his medical history, I want to remind that he had chronic kidney disease due to primary IgA nephropathy diagnosed 4 years ago. Back then, his serum creatinine was 2.5 milligrams per deciliter with an estimated glomerular filtration rate of 40 milliliters per minute. Since 2011, the decline of renal function was progressively accelerated of 4 milliliters per minute per year. In addition, he had secondary arterial hypertension due to renal parenchymal disease. The patient was compliant to hyposodic diet recommended by the cardiologist, but also to severe hypoproteic diet, about 0.25 grams per kilo per day, mostly vegetarian, but non-supplemented with keto analogues of essential amino acids without medical evaluation. For controlling blood pressure, he took 10 milligrams per day of calcium channel blockers and 20 milligrams per day of loop diuretic. In addition, for normochromic normocytic anemia, it was associated 6,000 units per week of apoetinum beta. The patient was programmed for arteriovenous fistula for the hemodialysis preparation. At physical examination, at first presentation, the blood pressure was around 145 with 90 millimeters of mercury without orthostatic arterial hypotension. His heart rate was about 66 beats per minute with normal heart sounds, with normal vesicular murmur, without pulmonary rales. The body mass index was 19.5 kilograms of square meter. At risk of malnutrition, And also he has involuntary reduction in body weight of 8 kilos during the last 6 months, and the screening for neoplastic diseases showed no abnormalities. At the BCM evaluation, he was overhydrated with an addition of 3 liters. From the laboratory tests, I will mention the serum creatinine of 4.6 milligrams per deciliter with an estimated glomerular filtration rate of 14 milliliters per minute. Moderate normocytic normochromic anemia with absolute deficiency of iron, hyperphosphatemia, hyperpotassemia, metabolic acidosis, and from the 24 hours urine collection, I will mention his proteinuria of 2.4 grams per gram creatininuria, highly selective. So in this clinical case, it is about a patient diagnosed with chronic kidney disease, stage G5A3 KDIGO, at very high risk with an accelerated decline of kidney function, with multiple metabolic abnormalities, with moderate anemia, with poorly controlled hypertension, overhydration, and with severe protein-restricted diet but non-supplemented. We talk with the patient, and along with anamnestic, clinical, paraclinical data, we've proposed continuing with the salt restriction. It was discussed the role of dietary restrictions and keto supplementation, and also the role of food diary. Our recommendation were to continue salt restriction, a protein restriction about 0.3 grams per kilo dry body weight per day, mostly vegetarian, but this time supplemented with keto analogues of essential amino acids, 1 capsule per 5 kilos dry body weight per day. His diuretic treatment was adjusted to the level of kidney function. And we've also administered 1.5 grams of ferric carboxymaltose to correct the iron deficiency. And we saw a dose reduction in erythropoietin stimulating agents. We also recommended for subscription on the waiting list for kidney transplantation. In evolution, we have noticed the correction of hydration status, well-controlled blood pressure, good compliance to the diet, good knowledge on the disease and the diet, and better reported quality of life. In January 2019, the BCM evaluation was in normal range. We noticed the correction of metabolic disturbances seen in the first presentation with normal values of serum potassium, serum bicarbonate, serum phosphates, with normal iron status and with a hemoglobin in the normal ranges. In addition, we have noticed the stability of kidney function comparative to 2011 to 2015, where we see an important loss in kidney function, approximately 4 milliliters per minute per year. Since 2015, the decline in kidney function was about 0.5 milliliters per minute per year. In May 2019, it was performed kidney transplantation from deceased donor. In the present, the patient has a normal kidney function. Amongst the benefits I have been discussed on the acid-base, hydroelectrolyte, and phosphocalcium balances, it is also very important how the patient perceives the nutritional intervention. Prior to the first presentation in our clinic, the patient told us his fear of the idea of dialysis. And because of that, he was excessively restricted about a very low protein diet without any medical evaluation. The consequences appeared and his nutritional status was compromised. Establishing a patient-doctor connection, he has been understanding the necessity of controlling his protein intake, but also the importance of associating the keto-analog supplementation. One with the good results, he has become even more compliant and more motivated in maintaining our recommendations. The patient-doctor connection has been maintained even after the kidney transplant was performed. More than that, the patient remained compliant to the therapeutic indications and to the monitoring of kidney function parameters. The second clinical case is illustrating the role of nutritional intervention in an elderly diabetic patient with chronic kidney disease. So a female patient, 80 years old, was referred to our clinic for the first time in 2012. From her medical history, we found out that she was diagnosed with diabetes mellitus for 20 years, insulin dependent for 15 years, with poor metabolic control. Her glycated hemoglobin was around 11%, and with microvascular complications associated, like non-proliferative diabetic retinopathy. She also was diagnosed with grade 3 arterial hypertension for 15 years. Since 2007, we saw that her serum creatinine progressively increased 1.1, 1.3 milligrams per deciliter with a persistent estimated glomerular filtration rate below 60 milliliters per minute and high selective subnephrotic proteinuria. From 2007 to 2012, it was remarked a progressively reduction in kidney function with a median loss of 7 milliliters per minute per year. Her previous therapeutic approach consisted in carbohydrate restriction, salt restriction, protein restriction, but with a non-compliant status for all the nutritional interventions, but compliant to keto-analog supplementation and to antihypertensive drugs. The medical treatment also consisted in administering basal bolus insulin therapy and erythropoietin stimulating agents with a necessary of 100 units per kilo per week. And prior to our first evaluation, it was discussed the necessity of preparation for renal replacement therapy. But the arteriovenous fistula performed 2 weeks before our evaluation recently had been thrombosed. At the physical examination, I will mention her blood pressure around 150 with 100 millimeters of mercury without orthostatic arterial hypotension. Her heart rate was about 80 beats per minute with normal heart sounds, normal vesicular murmur, without pulmonary rails, but with symmetric pitting edema in bilateral lower extremities. The BCM evaluation showed that she was overhydrated with a surplus of 4 liters. Her body mass index was 26.1 kilos per square meter. From the biological status, I mentioned the serum creatinine of 3.1 milligrams per deciliter with an estimated glomerular filtration rate of 14 milliliters per minute. She also had moderate anemia, normocytic, normochromic, with absolute deficiency of iron. Her glycated hemoglobin was around 10%. She had also hyperphosphatemia, hyperpotassemia, metabolic acidosis, and from her 24 hours urine collection, I will mention the polyuria, the hypostenuria, and the proteinuria 2.6 gram per gram creatininuria, highly selective. So in this Clinical case. It's about a patient diagnosed with insulin-dependent type 2 diabetes, poorly controlled, with microvascular complication, and for now I will only mention her diabetic nephropathy, with chronic kidney disease stage G5A3 KDIGO, with multiple metabolic abnormalities, with moderate anemia while on ACA, with absolute iron deficiency. In addition, the patient had poorly controlled blood pressure values and an uncontrolled diet with poor knowledge on its role. We discussed with our patient a new dietary intervention, starting with basic elements of dietary approaches in a diabetic patient and the role of dietary restriction and keto supplementation, and also the role of food diary. We have been recommended to her carbohydrate restriction, salt restriction, protein restriction, 0.6 gram per kilo dry body weight per day, mainly vegetarian, keto analog supplementation with 1 capsule per 10 kilos per day, and her diuretic treatment was adapted to the level of kidney function. We also administered her intravenous iron supplementation with no more ECA required. Our patient understood the role of nutritional intervention, became compliant to our recommendations. Thus, we obtained well-controlled diabetes, well-controlled hydration status, and well-controlled blood pressure. In 2020, we've noticed that the BCM evaluation was normal. And we also noticed a correction of metabolic disturbances. So we see normal serum potassium, normal serum bicarbonate, normal serum phosphate, and with an optimal iron status and with an optimal hemoglobin level. This graphic shows us on one side the accelerated progression of the kidney function decline with a median loss of 7 milliliters per minute per year from 2007 to 2012. And on the other side, the stability of kidney function from the moment we started the nutritional intervention. The patient's testimonial refers to the importance of knowing the role of diet, and she acknowledges also the rule deviations must be exceptions. More than that, educating the patient about the biological parameters that we often monitor, and in this case, I'm talking about serum level of creatinine, estimated glomerular filtration rate, her glycated hemoglobin, represent a key point in obtaining patient's compliance and in obtaining our results. So in conclusion, keto analog supplemented vegetarian protein restricted diet seems to be effective and safe in compliant patients with advanced chronic kidney disease, in ameliorating metabolic disturbances due to advanced chronic kidney disease, controlling blood pressure level, postponing renal replacement therapy initiation by reducing the rate of decline in renal function. Thank you for your attention.